All right. Well, hello, everyone. Welcome back to another Tuesday VMR from everyone, wherever you are in the world and whatever time it is. We're really appreciative that you're here. Alec and I are lucky enough to be back to discuss another case, and we have a new case discussion, which our case presenter, which we're really excited about, Dr. Lynn Taylor. So, Lynn, do you mind introducing yourself and just telling us a little bit about you?
Yes, absolutely. Thank you so much for having me today. My name is Lin Tang Taylor. I am a second year internal medicine resident at Providence St. Vincent out in Beaverton, Oregon. I am, outside of medicine, I am a quality improvement enthusiast, advocacy supporter, and mother of a 5.5-year-old little boy. And thanks so much for having me today.
Yeah, well, thanks so much for coming. And I think we were commiserating over the each virus that we get every week. And now your son's starting kindergarten, so I'm sure there's more to come. But hopefully he's on the back end of things. But yeah, if we can pull up the screen, then once that's pulled up, we can get started.
And then I'm just going to pull a Prof Res here and interject. And I'd say I agree with all that, except that it's Monday and not Tuesday.
Oh my
Um,
gosh. Thank you.
so yeah, really shout out to Vinny, who stepped in at literally the last minute to do the scribing, and to Kashar, who's doing the the teaching points today. And then yeah, once we get the screen shared, we can go ahead and get started. Austin, you want to take the first aliquot, or you want me to?
Sure, I'll give it a shot.
Awesome. All right, excellent. Whenever you're ready, Lynn.
Yes, so our chief complaint is altered mental status.
All right, perfect. Did you want us to start here, or did you want stop here first, or did you want to give us more information? What did you have planned? Whatever you have
So
planned is fine.
let me tell you a little bit more story because the kind of chief complaint and the diagnostic workup we are going to be talk about kind of happen later on in the course of the patient's hospital stay.
Okay,
So
great.
yeah, so this is a middle-aged man who presented to the hospital with fevers at home. He met 3 out of 4 SIRS criteria on arrival with fevers, tachycardia, and leukocytosis, with elevated lactate and an AKI. All of this is consistent with severe sepsis. The most likely source or sources of his severe sepsis are right lower lobe pneumonia and diabetic skin and soft tissue infection on his left transmetatarsal site. So he was admitted, treated with vancomycin and piptazole. Later on, vancomycin was discontinued after Mosanet became negative. On hospital day 3, we got a page at about 7 a.m. That patient was found by his bedside nurse to be altered, lethargic, and not responding to painful stimuli. And I will leave it here.
Wow, yes, an explosive start. So thank you so much for laying that and presenting such a complex course so seamlessly. So yeah, I'll give my broad strokes overview, Alec, and then I'll pass it along to you. But I think this is not an uncommon space that we're in, where we'll be admitting a patient, taking care of them, watching them as they go through their treatment course, and then something comes up, whether that's improvement in the way that we were hoping for, or a complication that arises. And so I would say that when I'm in this space, it's not so much that I approach it differently than I would for someone with altered mental status. It's just sort of layer on, okay, what is unique about this particular situation that I need to add to my approach to altered mental status, which I like to use the MIST mnemonic, as many of the CP solvers enthusiasts do. So metabolic, infectious, structural, and toxin. And I would say in someone that has a really kind of hectic inflammatory syndrome, I'm thinking about, consequences of that inflammatory syndrome, or I'm thinking of consequences of the treatments that we've given them for that inflammatory syndrome. As far as how to make progress from here, I think one of the things that is really helpful is trying to define altered mental status a little bit more. Like, is there a true focality in the altered mentation, or is it truly like a global phenomenon? And I think already in someone that is they're not elderly, middle age. We didn't get the exact age, but I'm assuming the patient's going to be in their 50s. And we see that they're lethargic and obtunded and not responsive to painful stimuli. So I'm going to say this is a global issue without clear focality. And so really in this space, I'm more, as opposed to a structural lesion, I'm more in the metabolic and sort of systemic process that's going on. So whatever's, as opposed to a focal lesion in the brain, something that's affecting the brain by whatever it's being bathed in. Yeah, I sort of rambled along here, but I don't want to invest too much right now since I think the differential diagnosis is so broad. But Alec, what additional thoughts do you have?
No, Austin, you didn't ramble at all. I thought that was excellent. And, I think the way I think about patients such as this is, is this something that is related to the patient's ongoing disease that they're presented with, or is this something that's truly new? So I guess I would also be curious to know what's going on with the SEER status. Is the patient improving appropriately? Have they been getting worse? Have they been getting better? What exactly has changed in the interim time? And I think the background of the patient, so we already know that they have diabetes, um, and I imagine they may have some other comorbidities related to that. And I think the background would definitely help layer things in. I think in the hospital, oftentimes when people have an acute change in the mental status, it's often something that we did to them. And, the further you are into the hospital course, the more likely that tends to be. And, we had a great case by our amazing Mark regarding that. Not necessarily something they did, but something that acutely changed during that time. So, in particular, when somebody's in the hospital, I one of the first things I think about are medications, either medications that we're giving the patient, and I think really attention needs to be given to the patient's renal function as well, as often many of the medications are cleared by the kidney, and whether or not any of those can be contributing. And then also, oftentimes people come in. One of the most important things that we have to do is the medication reconciliation to see what people are taking, because there are some medicines you can stop and there aren't immediate consequences, but there are other medications that you don't want to stop immediately, baclofen being an example, or maybe on somebody's on benzodiazepines or whatnot. So that's something that at least that was a type 1 reflex thinking to me. But yeah, I think just trying to clarify more, is this something that's related to the disease that the patient presented with, or something a little bit different, or a consequence of something that we've done to the patient? So I'd love to learn more about the patient's background. And I totally agree with you, Austin, that given the lack of focality and sort of the hectic signal outside of the brain seems to be a bystander here. But as the case progresses, hopefully we'll be able to continue to add fruit to that and make a little bit more diagnostic progress. But yeah, Lynn, I'd love to hear more what happened next.
Absolutely. So let's provide some more history. Our patient has a very complex past medical history. He has a history of CAD, has undergone multiple PCI. The last one was in 2021. He has a history of CKD3, baseline creatinine about 1.5, history of peripheral arterial disease, and he underwent left femoral bypass with right below knee amputation, also have a left transmetatarsal amputation. He has a history of DVT. He is on apixaban. History of type 2 diabetes on insulin. And history of quadriparesis due to cervical myelopathy. For medications, because of the complex past medical history, we have quite a few medications. Amlodipine for hypertensions, atorvastatin, carvedilol, hydralazine, isosorbide mononitrate. For muscle spasm, he take baclofen. For diabetes, he take metformin and insulin. He takes a few medication for constipation. For allergy, he takes diphenhydramine and loratadine, PRN. And for insomnia, he takes trazodone, also PRN. No significant family history. Social history, he lives in an adult foster care home. He's mostly wheelchair bound, but is able to move around on his electric wheelchair. Health-related behavior, he does have a history of substance use disorder, specifically methamphetamine. And for allergies, we have anaphylactic reactions to amitriptyline and bee venom.
And what is that hope? Is that where you were hoping to stop after this, Alec?
Yes, and I
Amazing.
think we'll stop right here.
Okay. Wow, just really want to applaud you for presenting such a complex past medical history very clearly. And Vinny, amazing job keeping up. That was amazing. So yeah, a very, very rich and complicated past medical history that, oftentimes when you get paged for patients like this in the ER, even now as an attending for almost 5 years, like I still get overwhelmed. But I think when you're admitting a patient, just trying to figure out what is acute and needs to be understood and then managed now is exceedingly important. And then some of those other details, you could dig through the chart once the patient has stabilized. But I think significant cardiovascular risk factors, moderate kidney disease, a very complex, surgical history here. The patient is on anticoagulation, and then the quadriparesis from cervical myelopathy is notable. I guess we'll still hope to get clarity on what the sear is coming from, presumed to be infectious, but the exam hopefully will be elucidating along with the labs. Based off the past medical history, certainly the lower extremities would be one to consider, and then whether or not there's an ischemia component to this versus a side effect of his diabetes will be important to know, and hopefully we'll get a better sense of how well some of his comorbidities have been controlled, particularly his diabetes as well, and his adherence to his medical therapy overall. I think would be quite helpful as well. As far as the medications are concerned, a lot of them are very common medications we see, but I think the ones that really struck out to me because of the potential side effects of either taking them or not taking them struck out to me, and that was the apixaban. This patient does have quadriparesis, gets around in a wheelchair. Could he have fallen at all? We're unaware of. Could he have had a spontaneous bleed? Is something else going on? He does have a history of clots. Was he not taking the medication and developed a consequence from there, and now has either DVT or some other hypercoagulable process that's driving his presentation. The baclofen is also one that we see quite frequently in patients that have quadriparesis and can make people sedated, but can cause a very significant withdrawal syndrome if not given. So I guess I would be very curious to know what the dose was, how long the patient had been on it, and also if that's been something that he's been receiving at his typical home doses while he's been in the hospital. And then the insulin is another big one, right? Especially as the kidneys get worse, you often need less and less insulin because it's cleared by the kidneys, and the risk of hypoglycemia certainly goes up. And I'll tell you, when I was a second-year resident, I decided to give a patient with advanced CKD 10 units of insulin for hyperkalemia, and then they ended up in the MICU because they needed a Z5 drip. So, you just got to be conscientious. And I think it's another sort of teaching point as well, that as you might notice that patients with diabetes, as their CKD progresses, typically their diabetes gets better. And it's multifactorial, but often that has something to do with how quickly the insulin is cleared from their body as well. The family history, not much to layer in here, and I don't think it's pertinently relevant. And the substance use disorder history is very important. I would be very interested to know how the patient uses their methamphetamine, whether he smokes it, injects it, and that could bring other certain things to mind. How frequently the patient is using it. When was the last time the patient used it? Stimulants also often as a side effect after the stimulant has worn off. People can be quite somnolent afterwards, and then sort of can slowly wake up, become very hungry as they recover. But it seems maybe a little bit less consistent with that. But I would love to know sort of the surrounding history of that, whether the disease is in remission or whatnot. And the allergies, good to know. There's anaphylaxis to those things. Hopefully he wasn't stung by a bee in the hospital, so that we'll be good there. But you never know if the window is open or something. But the amitriptyline doesn't seem like the patient has been exposed to or any related drug. So hopefully we'd be okay there as well. And I think another important thing to clarify for patients that have such a complex past medical history is really getting a good sense of what their mental baseline is. And so, at this point, when he's altered, I guess I would be curious to know when he did present to the hospital, what was his mental status like, or if he was mildly altered at that time, getting collateral from the family or his living facility about what he's normally like. Is he altered at baseline? How much does he understand about his medical conditions? Is he oriented? It seems like he requires some assistance for his ADLs with his prior quadriparesis, but also something important to clarify. But a very rich past medical history and medications and social history to layer in. And I would love to hear what Austin's thinking about this as well.
Oh, really not much left to add since you went through everything in so much detail. I think I would say that this is a relatively younger person, middle-aged, and so I was asking myself, how could we get to the point of basically the patient being obtunded? And we've learned that this patient is not a normal, unfortunately has accumulated a fair number of comorbidities, and so has susceptibility to delirium or sort of the consequences of systemic disease on his brain, since unfortunately at baseline it's not operating particularly well. So I think the past medical history just really paints the picture that this is a susceptible host for multiple different regions, but including a sort of alternation of the global variety, if you will. I think the other thing to say is that in someone that has substance use disorder and has it has disabilities, I think the physical exam can be a real challenge. I mainly practice in the outpatient setting, and so being able to perform a really good physical exam on someone that is wheelchair bound, it can be really, really challenging. And in the hospital, you have the luxury of getting them to the bed, rolling them over. But I think for this particular patient, I would have to be really mindful of, as you said, about kind of where and how they're using their drugs, but also just being thoughtful that, okay, am I missing something as far as where they're applying pressure on parts of their body? And also, they can't report to us not only because of their mental status, but also because of sensation about if they're having pain in a certain part of their body. So really doing a really, really thorough physical exam, maybe more so than you would for someone else that had intact sensation or didn't have quadriplegia, would be really, really crucial. And so that whenever I have a patient that it's more challenging to do sort of our traditional exam on, because it's not as easy of just asking them to get over to the table or turn over on their side, then asking for help in those moments is really, really important, because you will 100% miss an ulcer on their back if you're not going and looking for it. I think there's not a really joke, but a sort of like a mantra about like how to hide a $100 bill from an intern is to put it under a bandage. And so just want to be mindful of that and respectful of that, because this is something that patients with disabilities, this is something that really impacts their care a lot. So we have to be mindful of that. So thanks so much, Lynn. Let's get the next piece of information.
Yes, before I kind of provide more information, let me answer a few questions that you both Alec and Austin have raised. So patient was taking his apixaban. He does have at baseline, he does have an understanding of his past medical history. He doesn't quite remember the names and the dosage of his medication, but his adult foster care home does a really good job at making sure that he takes his scheduled medications on time. The dosage of baclofen is 15 milligram 3 times a day scheduled. The dosage of his home insulin regimen is Galage 20 units at night with a correctional scale with meal times. During this hospital stay, he was being given Galage 10 units with correctional scale, and glucose was being titrated very closely, mainly for hypoglycemia more so than hypoglycemia, because patient does eat some food that was brought into the hospital by his visitor. For his substance use disorder, he last used methamphetamine just 2 weeks ago, and he inhales. And at his baseline mental status, he's a very pleasant middle-aged man who is oriented times 4, knows why he's in the hospital, and completely clear. And per chart review for his night nursing note, he was able to answer questions just a few hours ago. And then, so with that, I'm going to move on to the next piece of information. I got the page right around where I can't remember, but I rushed up from the second floor, and our patient vital signs. temperature 37.1, heart rate 85, respiratory rate 22, blood pressure was 208 over 121, 91% on room air. On physical exam, when I was in the room, patient was obtunded, unable to answer questions. He awoke to very, very strong sternal rub, but can't follow instructions after. He has a gag reflex. Exams otherwise is very normal. He can't he can't squeeze both of his hands up. He can't move his legs, obviously. And heart and lung sounded normal. And I think it's going to be the most helpful in this aliquot as well for me to provide kind of a rapid response code was called and what happened next before we moved on to the labs and chemistry in the next aliquot. So patient was given naloxone 0.4 milligram times 2 without improvement. He was evaluated at bedside by our critical care attending, who deemed that intubation for airway protection was not needed because he does have a fairly strong gag reflex. So he was transferred after some workup. He was transferred to our step-down unit for closer monitoring, continue being encephalopathic. But his respiratory rate was 5 upon arrival to the step-down unit with 25-second periods of apnea. And his saturations maintained above 93% during those apneic periods. And I will leave this aliquot right here for some more discussion.
Okay, and thanks so much. Just to be clear, was the patient receiving any opioids like during their stay that we know of? Like it was on their medication list, like as needed for pain or anything like that?
Yes, he wasn't getting opioids pain medications, but mainly because there have been quite a few visitors coming to see the patients. We were worried about opioid overdose. Yeah.
Okay, perfect. And then this episode of basically apnea happened once the patient was transferred to the step down, and we don't know, this was the first time such an episode had been observed before.
That's correct.
Okay, and then okay, then I'll before I ask more questions, I'll just try to layer in my thoughts, and then Alec can take over. So, but thank you so much for clarifying all that. Okay, yeah. So, you know, a really scary moment where you go to see the patient and basically you're sternal rubbing them, and that's the only way for them to really arouse. And this patient, you know, is unable to really follow commands at all. And then doing your sort of standard assessment to look for focal deficits if you can, like testing for reflexes, the squeeze, the looking for clonus, those sorts of things. Like all those things are unfortunately going to be confounded by the patient's baseline neurologic issues. And so a really, really challenging space to be in. And then we didn't hear about the pupil exam at the time, so that might interest me as well. But you know, there are there can be some caveats to that and make it difficult to interpret, but I think that will be interesting to hear moving forward. So as far as how to approach this space, I think Kashar put it in his excellent teaching points already, but to approach a patient that's acutely obtunded. So I think first thing you want to do is check a sugar. So you want to say, hey, this patient has had risk for hypoglycemia, but it's reasonable to check in anyone. And it doesn't seem to be an issue for this particular patient. If anything, they've been dealing with hyperglycemia. The second to be is empiric naloxone. I think it's a very reasonable and appropriate thing to do to give the patient naloxone, even though there wasn't any opioids that we were providing to them necessarily, because as you're right, people come in and oftentimes if people feel uncomfortable with their sharing their substance use disorder or feel stigmatized by that, they don't necessarily share that they're using those substances, and sometimes bring them with them and use them in the hospital. So that's certainly a scenario that I've been in as well. So I think it was really amazing that the naloxone was given, and appropriately so that it was done. But the patient didn't have a response, so that kind of lowers our suspicion that that's at play right now. The other is oxygen. So we already looked at the oxygen levels here, and that sort of falls into the other vital signs, but really nothing stands out besides the blood pressure. I imagine there's probably some chronicity to that, but if it seems like the hypertension was a new thing, or if we go back to the vitals trend, there was a bit of a change, then that's something that we would want to explore a bit more. In particular, this patient has risk factors for PRES, so I'm going to put that in the back of my mind for now. And then I think the last one would be sort of empiric thiamine. I use the mnemonic don't. I see the mnemonic scan there, but I use the mnemonic don't, which is dextrose. So it reminds me to check a sugar or just give sugar empirically, oxygen if there's hypoxemia, naloxone for opioid overdose, and then thiamine in case you think someone has Wernicke's encephalopathy or other aspects. Though usually doesn't present hyperacutely like presumably the situation is, or I would make that assumption for now. So as far as what problem we're solving, I think I'll leave that to Alec to say, but I think the thing that is more helpful, and I'm going to make the leap that this apnea is overlapping with the patient's mental status, and I think that's how I'm going to solve this for now. So what can cause significant apnea and basically hypopnea? So basically the patient or bradypnea, excuse me, the patient has a low respiratory rate, and in periods where they're not breathing at all. So I think substance or exposure is the number one thing I would think about, opioids being the top of the list. Certainly there are other medications that can suppress the respiratory centers, but realistically speaking, those are, it's usually drugs that are given intravenously as opposed to orally, like outside of opioids, that at least I can think of. And so Alec, I lean on you since I work in the clinic if there's any ones that I'm missing, but really, even benzodiazepines in particular don't suppress the respiratory drive that much unless given intravenously, and usually with other substances in and of itself. So in a patient that has a substance use disorder, I will be worried about if there could be any other substances at play, and if anyone had brought them anything in particular. But that's sort of lower on my list right now. And then the other thing is, secondly would be, if it's not a substance or exposure or something, again, bathing the brain that's affecting the respiratory drive, then I'm worried about either a lesion in the brain or something intrinsic going on with how things are functioning with the respiratory center that could be driving this. And the one that would be most common is just sleep apnea, for which the patient has risk factors for sure. And so I would be curious if the patient has an underlying diagnosis of sleep apnea or has ever been hospitalized in the past and there have been witnessed episodes of apnea, and that will be crossing my mind as well. Other than that, I think I'm in a space that I've never really been in before. And so, I would think about definitely, given the level of issues and the difficulty of finding any focality due to the sort of caveats of the exam and the limitations of that, I definitely would be imaging this patient's brain most likely after our initial sort of diagnostic evaluation with basic labs if it became unfruitful. And I'm glad that they got escalated into their next site of care to make sure that we're appropriately looking at this patient's airway to make sure that they don't need intubated at some point in time. It doesn't strike me as a person that would be appropriate for BiPAP if there was a gas that showed that they were retaining. And then obviously if they're apneic and those episodes are lasting for periods of time, I think unfortunately this patient will be heading towards intubation. But yeah, Alec, I'm a bit perplexed. What are your thoughts?
No, Austin, that was excellent. I don't know if I have too much more to add. I do think the scan or the don't would be very important in that situation. The patient is still very much at risk of hypoglycemia, and the change seemed to be sort of hyperacute to acute. And so I definitely would be going for that. The lack of response to the naloxone, sometimes patients just need a higher dose. So I'm not sure if we've excluded that entirely. But something to consider in that situation. Very rarely naloxone has some side effects, including pulmonary edema, that you have to take in mind. But I think it would be helpful to know. It seems like the patient had, intermittent visitors. Now, I would love to know, like, the change of the mental status that happened immediately after. Did he ingest anything that they brought? Are they temporally related or not? Not to pass judgment, but just sort of expand our differential there about whether the patient was willingly or unwillingly given something. I've had a couple instances where the patients may have gone outside and ended up smoking a substance and came back and they were quite altered, and just to see what could be going on there. But I think certainly the degree of hypertension is a bit striking, and I would love to know what the patient's blood pressure was before all this happened. He does have a history of hypertension, but 208. and he's potentially symptomatic, that's sort of concerning. One for a primary CNS event, whether the patient could have increased intracranial pressure. The heart rate is normal, but I think the patient is on a beta blocker, maybe. No, maybe not. Looking at the med list,
They
but
were on co-reg, yeah.
on co-reg, okay. So would wonder if that's changed. The heart rate isn't quite low to like fully elucidate Cushing's reflex sort of triad, but I assume that there are patients that are not bradycardic during those episodes as well. And the patient also is on an anticoagulant and other things. So I definitely would be scanning this patient's head. And I imagine like trying to pick up focality in the moment when they're not really able to fully participate with you might be difficult. But I think the pupil exam will be extremely elucidating, not only to assist you with whether or not there could be some sort of toxidrome at play, but whether or not they're asymmetric or there's something else that's going on there that would make you want to image their brain even sooner. And the patient certainly has risk factors for essential sleep apnea or obstructive sleep apnea. We don't know what the patient's BMI is, but this seems to be acute. The patient's been in the hospital a few days. We didn't get a sense of they were having some of these episodes overnight in the past. Something has changed, and we need to figure out why. I'm not sure if the patient has been getting the baclofen or not. This presentation, hypertension could fit with baclofen withdrawal, but I don't typically think of sort of bradypnea as something that's associated with that. But I'm keeping it in the back of my mind. And I do think a VBG to assess for hypercapnia will be very important, and totally agree with you, Austin, that this patient probably would not be appropriate for trying the BiPAP and may just need to go directly to intubation. Because I've missed hyperammonemia in the past, there's no tachypnea here. I think that's a little bit less likely, but something to consider for ultramentation as well as whatever else fits into your missed mnemonic. But I think I'm very, very concerned about this patient. I want to know more about the blood pressure, how much of this is new or not. And then I think, oftentimes when patients are non-focal and we have a clear other cause for ultramentation, you don't always need to do a CT scan, but I think there's enough red flags in this situation with the elevation of the BP, particularly if it's acute, his sort of profound bradypnea. He's also on apixaban, so is at risk for a bleed, has numerous vascular risk factors, so could in theory have had any sort of vascular event in that moment as well. And then, I think I would be curious to know other aspects of the physical exam. How does the leg look? Were there wounds elsewhere on his back? What was the cardiac exam like? Other things that I think would be important to sort of piece out. But those were the main things I would come to mind and say, just sort of expanding on things. But I think definitely we need to figure out what's driving this bradypnea or sort of hypopnea or I guess hypoventilation. But I guess we'll see based off the labs if we see that, and sort of can build our differential from there. But I think we're still solving ultramentation, but he has a few unique features that might overlap and help us later on down the line. But Lynn, I would love to hear what happened next.
Yes. Before I dive into what's happened next, let's provide some more of the details that were being discussed. So pupils exam were done very carefully by me, rapid response notes at bedside, and then our intensivist attending as well. People was equal, round, and reactive. And the left transmitter tarsal site at which we were thinking there was a contributions to the severe sepsis actually has looked much improved compared to the day of arrival. The patient doesn't have any history of sleep apnea, no diagnosis of obstructive sleep apnea or central sleep apnea. In terms of intermittent visitor, the patient last had visitor that night nursing team was aware of in the evening the night before for an extended period of time. And then the mental status change happened this morning. For the hypotensions, we have had to hold a few antihypertensive medications during the hospital stay because of the acute kidney injury. So there has been some increase in blood pressure over the last few days, but it has not gone above 200 systolic, and there have not been any symptoms. So asymptomatic, severe uncontrolled hypertension, so it was not being treated. The baclofen, patient has been getting his baclofen. And so with that, I am going to take us to the next aliquot with all the workup that were done at the rapid response call, and following kind of a little bit into the early hours of the stay in the step-down unit. We did a workup with complete blood count, CMP, lactate, troponin, magnesium were all normal. We had an ABG that was normal. Urine drug screen was negative. Oh, I'm so sorry. CMP was not normal. CMP was the abnormal lab that was notable for a creatinine of 2.8, up from 1.3 the day before. Patient was sent right away for a CT head without contrast that showed no acute intracranial changes. And after he was transferred to the step-down unit, started having this apneic episodes, he was monitored much more closely, was having sitter at bedside, and over the next few days, we deemed that his mental status, his AKI is most likely pre-renal due to sepsis, probably with some exacerbations due to contrast-induced nephropathy, as he has been getting a few CT scan in the workup of his severe sepsis. So he was aggressively fluid resuscitated, and creatinine gradually improved over the next 2-3 days in the step-down units. On day 3, after this episode of altered mental status, we found patient in the morning completely normal, talkative, suctioning himself, left that morning was notable for a CBC a normal, a BMP with creatinine downtrending to 1.8. And I will end this aliquot here.
Wow, thanks so much, Lynn. Very, very interesting here. So just to be sure to sort of summarizing things correctly. So he, on that first day of the rapid response, had a very significant AKI. Seems like over the subsequent days that improved with resuscitation. His infection seemed to be overall stable. His workup beyond the AKI was fairly unrevealing. And then over the next couple of days was sort of stable. And then on the third morning when he woke up, he was just back to normal.
Yes,
Okay.
that is the story.
Okay, very interesting. So, I mean, I think our first pass workup regarding the mystomotic was entirely unrevealing. The pupil exam was reassuring. The blood pressure seemingly had been creeping up, but there wasn't, it didn't go from like 120 to 200 instantaneously. And he had been getting all of his medications. Seemingly most of them were renally dosed. I guess I would also love to just run all the other medications he was getting in the hospital, the antibiotics, the pain medications, whatever else. And I think that would be helpful to know just because some of these medicines can have a lot of side effects. And as the AKI improved, perhaps one of these substances was further metabolized and no longer causing him toxicity. So I guess that would be helpful for me to know what he was on. I think one of the ones I think about in the hospital, particularly for patients that are on antibiotics for diabetic foot infections, is cefepime causing neurotoxicity. Although a lot of times those patients have asterixis and are very, very obtunded, but sort of can have some jerky movements. But the presentation can be highly varied. So I'd be interested to know what antibiotics the patient received. Like meropenem can also do it, but it sounds like the patient was on Zosyn, but I'm not sure if that had been changed at some point. Piptazo can also cause a sort of elevation to creatinine without affecting the GFR, similar to Bactrim, because it can prevent the secretion of creatinine. If it got better and the Zosyn was continued, perhaps that was less at play, but just another consideration there. And I guess, Austin, I'm just really struggling to know what to do sort of with the spontaneous resolution, and whether that's just related to something clearing with the kidney injury, whether that was some sort of toxic metabolic insult that just was self-metabolized and resolved, whether that was an ingestion, or whether or not he had some other sort of acute CNS process that just spontaneously improved, with press being one of them. I also wonder if during these episodes, if they sort of waxed and waned, could the patient been having focal seizures at that time? The CT head, not without contrast, is pretty much only good to tell you if the patient has a bleed. And that was negative, but it's not really going to tell you acutely if the patient has an infarct or, if they have small bleeds or something else is going on. So I think depending on the patient's time course, and then once the patient is more recovered, whether there's any focality at the exam, just keeping in mind whether or not the patient might need, additional, more dedicated and specific CNS imaging, including MRI. Or imaging of his vessels in particular. But he doesn't have sleep apnea. His ABG is better than mine. I'm not exactly certain how to make too much more progress here. So I guess at this point, I would just be falling back on the mnemonic still. It seems like most likely there something acute that changed and we just haven't figured out what. So I'd be really scrutinizing his medication list closely, trying to see temporally if it was related to his visitors or not. Did the patient not have visitors over the last couple of days when they got better? How soon after? So it sounds like in the evening he had a visitor, and then the next morning he was initially altered. So I don't want to anchor too much on that, but just something that seems a little bit peculiar. And then really asking myself, what other dedicated imaging his brain, if any, do we need to consider? I don't think there's, I'm not racing here or getting the sort of smell, if you will, of a primary CNS infection, and seemingly has self-resolved. Yeah, I'll just say I'm not exactly sure what to do from here, but it seemingly there's some sort of transient CNS process that has resolved that seems to correlate with resolution of his kidney injury. So I wonder if there was something that had built up that has now improved. But I'm pretty sure I'm missing something. Austin, what are you thinking here?
No, I think I'm having the same tensions you are, and I would say that I think what we're really struggling with is understanding the time course of like how did the patient's altered mentation start, and then how did it end? Was it really more of like a gradual onset that happened, or was it like this hyperacute and it's persisted since then, and then hyperacutely came off? But I think if we talk about the potential etiologies of a hyperacute syndrome, most of those are going to resolve quickly, right? And if we're invoking the possibility of like non-convulsive status, for example, this is something that would probably have a tail end to it, and not something where he's just going to miraculously sort of return to normal cognition. And so when I think about the stories of the hyperacute syndromes and being on and being off, the time course really does fit with that. So I think, as you said, that lends credence to the fact that we're in sort of this state where we're kind of slow on and then slow off, and what changed during that period of time. So as you said, I think I would scrutinize, what changed metabolically for the patient. So it seems like we're getting signal that the renal function have changed. I have to say, I'm going to be honest, I'm not sure if the renal function changed. And I guess with now that I say that, I'm not sure how muscle wasted the patient was related to their quadriplegia. So maybe the patient's creatinine is suggesting that their kidney disease is actually significantly worse than we're giving credence to. Because I have to say, in my experience, like, I'm not sure that I would be that concerned about toxic buildup from a creatinine change from like 1.8 to 2.3, if I wrote down the numbers correctly. Like, I'm not sure if that's enough of a change for me to wonder if there could be like a buildup of toxin, like if the therapeutic threshold would be reached. Though in this vulnerable patient, I guess that would be possible. So I'm right there with you as far as the kidneys and the change of the GFR and how the patient's exposures in the hospital related to the medications that we're giving them, plus maybe any exposures that the patient was given related to their friend or whatever might have been going on or at play. I guess I'm still struck by the apnea and the causes of that, and I think that's something that requires significant explanation. And so I was going to ask Lynn, was this a one-time isolated event, like never happened again? Or was this something that happened during the 3 days when he was in the step down unit? Like, this is something that happened over and over again?
Yeah, so this actually happens over and over again, which really concerns our nursing colleagues. And I mean, I actually went to bedside multiple times and kind of watched these episodes as they happen as well. Um, and there was no seizures activity, but obviously that doesn't rule out like convulsive seizure. In terms
Hmm.
of medications, Alec, in the setting of the worsening AKI, actually AKI went up to 2 point, creatinine went up to 2.8 from 1.3 the day before. We treated as pre-renal and also hold a lot of all the nephrotoxic medications as we usually do in the hospital. So um, among that is some of his home anti-hypertensive medications. Actually, I don't think there was any antihypertensive medication that was held, but we was holding furosemide. We were giving a little bit of diuretics to help with pulmonary edema on arrival. And then we held baclofen as well in the setting of his worsening AKI. I don't know if that would help at all.
No, but I appreciate the alley oop. But I guess the other thing, since this was a recurrent thing that happened at the bedside, it does bring to mind the possibility of some of these sort of cyclic disordered breathing episodes that can happen. So I think about like Chang-Stokes breathing, and there's many different versions that exist. I have to say this pattern of like slow breathing apnea, and I'm not sure what happens next. If that could fit into a particular pattern, and if that's associated with particular exposures or his comorbidities necessarily. But I'm sort of lost. I agree, Alec. I'm not really sure. So is there anything else you have to add, or should we just have Lynn help us out a bit more with whatever information she has, or if we're going to reveal the diagnosis, or what do you think?
I guess, Lynn, I guess how many more Alcots do you have before you reveal the diagnosis, or
I
are you going to reveal it now?
Yes, I was gonna review it now because I don't
Okay,
think there's any more
then maybe I
information.
can just challenge myself if you don't mind,
Yeah.
just to see if I can think about this a little bit more. So, um, yeah, I guess I really don't have a good illness script about what causes sort of acute onset apnea besides really toxins. And I guess you could think about there's something going on in the brainstem. But if that was related to a vascular event, I wouldn't imagine it would be transient. I would have to do a little bit more reading on press and other things if that has been described. Seizures would be another consideration, that maybe sort of a really focal um, seizure, but I think that's also a little bit less likely. But um, yeah, I guess the baclofen. I imagine the patient's creatinine more than doubled. So I'm just going to say that's probably enough to lead to the buildup of some of these, and whether the patient would sort of start metabolizing them. But if the drug is there the whole time, I'm not really sure why the episodes would be transient. Um, so I'm just a little bit perplexed. So I guess my best sense is that there's something hyperacute that's sort of coming and going related to sort of metabolic changes or medications that have built up, or there's some sort of acute event related to some CNS pathology, whether that's press or seizures or something else that I seem to be missing. But yeah, that's my best shot at it. Austin, do you have any final thoughts before Lynn reveals the diagnosis?
No, I guess how do you think we're going to get to the answer here? I guess I'm still going to image this person's brain, I would say, just because I think the fact that they woke up spontaneously and everything seems back to normal is certainly reassuring and speaks to something on and then that left. But I think uh, maybe there is a sort of predisposition within their brain that we haven't recognized, and certainly has risk factors for stroke. So wouldn't want to miss that happened. Not necessarily that it would change management too much, but I imagine, like, yes, reviewing the medalist and the time course and maybe a lab that we're missing is going to get us the answer. I probably still would image this brain, but I'm not sure if there's any other final tests that you would get to help you along here.
Yeah, I mean, I think I still would be considering the MRI brain, and I think really keeping a diary of when the patient's symptoms are happening And then, is sort of at the same time figuring out what medications he's getting or anything else around these apneic episodes and how frequently they're happening, I think would be something that would potentially be helpful. I feel like because this seems to self-resolve, it makes me think that it's something that we have done to the patient. But it seems like the blood glucoses have been fine during these episodes. The labs, besides the kidney injury, are otherwise unrevealing, although sort of that begs the question, what caused the kidney injury to begin with? Yeah, so and I just keep going back to this more as my experience as a hospitalist, just medications, and then would be keeping in the back of my mind, really just additional CNSS imaging, or could I be missing a focal seizure? But Lynn, I would love to learn what you guys were thinking at this time.
Yes, wow. Everything that you and Austin have said are just completely right on the dot. And I don't know if it's a matter of me like not being able to kind of present it in a more clear way. But so our patient have a history of muscle spasm, and he was getting the baclofen, 15 milligram 3 times a day, with the presentations of altered mental status, coupled with this episode of recurrent apneas. But and that very profound AKI we found on the day of the onset of encephalopathy, plus resolutions of encephalopathy with resolutions of AKI, we concluded that this patient's etiology of the acute encephalopathy is most likely due to baclofen toxicity in the setting of AKI. And then on further reading, respiratory depression is a symptoms of baclofen toxicity, and toxin can build up fairly quickly in patients with kidney disease. So that really kind of convinced us that that is what happened. And patient did not receive any further imaging. He continued recovering really well after that, and left the hospital just 4 days after the resolutions of encephalopathy. And I will leave the end of this right here.
Okay, Lynn, thank you so much for such an amazing case. And yeah, I think doing a quick cognitive autopsy, I think all the reflexes were there, and that I think we were having the sneaky suspicion that it was something that we were giving the patient. And I think in patients like this, when the episodes are acute and intermittent, especially in the hospital, I just love to keep a little diary about what was going on around the time of the patient. What did they eat? What medications did they receive? Who visited them? Did they work with physical therapy? Like, what exactly had changed? What were their vital signs at the time? What were their labs at the time if they were checked? And I think that's how we would have gotten to the answer at this moment. And good to know that the baclofen in that moment wasn't reduced. And I think certainly that makes a lot of sense, and that these episodes were intermittent because the drug had built up and then was going away, and then weren't happening anymore once the patient's kidney function returned to baseline. So certainly makes sense. I'll have to do more reading about, I know it can cause CNS depression. I guess if it gets bad enough, I assume apnea would be the endpoint of that. Sort of really interested to see in those moments that the patient didn't have any clear evidence of hypercapnia, but I guess he was sort of compensating in that moment. But yeah, I think that was a great case, like something that's very real life. Like, we see patients like this all the time, and these complications come up. So I really thank you for bringing such a case here to VMR, and it was awesome to discuss. But Austin, what are your reflections on the case before we pass it over to Kashiar for the teaching points?
No, great reflections. And Lynn, no, your presentation was superb. It has nothing to do with your presentation. We were just garbling on about everything. And no, I think, as you said, I think I was understanding the time course of onset and offset. I think that was really the crux of this case, at least for me. So a lot of the times when we're thinking about a substance exposure, really, most of the time it's like quick on, quick off. But then there was the second dynamic variable that happened in the changing renal function. And I think that's really what tripped us up a little bit. And so we definitely brought on substance, but I think when we think about, at least for me, when I think about substance on, substance off, it doesn't usually have this kind of tail to it. And maybe that's just like but my practice bias. But I think, how many times do we see people's creatinines go up and down? And certainly the baclofen, I was even in the middle of this, like, it's like, man, 15 TID for a guy with CKD3 seems kind of high, just on my experience. And so I was looking that up, but it seems like that's a reasonable dose for someone to build up to over time. And so it didn't really cross my mind. And then certainly baclofen isn't something that if you stop it for a day, like miraculously it's out of your system. So it's different than like cocaine or methamphetamines or something in that regard. So I think that was really my takeaway here. But no, Lynn, amazing case, amazing presentation. Thank you so much. And lots to learn and reflect on. So let's pass it on to Kashar for the teaching points. Unless, Lynn, you had any other teaching points that you wanted to share.
No, I think I'm excited to hear Kashaya teaching point for us.
And thank you so much again for presenting the case. Thanks for Vinny for scribing. And Kashir, my kid has a fever, so I have to step out early, so I made you host. But thanks again for everyone's help today and for solving. And I'll pass it to you, Kashir.
Thank you so much, Lynn, for the amazing case, and thank you so much for the great discussion. Let's go approach the teaching. So we're started by approaching the AMS using our usual missed mnemonic, but we have to consider that this is a new presentation in a hospitalized patient with a complicated history. So we have to ask ourselves, what is unique here? Is this a consequence of the inflammatory syndrome the patient is coming in, or is this the part of the underlying disease, or is this the consequence of the treatments we are giving the patient? Also, we need to define the altered mental status here, focality versus global phenomenon. Is this a focal lesion causing AMS, or is this a global thing that is affecting the brain? In another way, we can say it is the brain a bystander, or is it the cause? Before moving on to diagnostic workup, we have to remember our immediate management, things we can do immediately to bring back and stabilize our patient. Two mnemonics that were mentioned is the scan mnemonic and the don't mnemonic, which was new to me and I really enjoyed it. The don't mnemonic mentions dextrose to always check the blood glucose and treat that. Oxygen, check if the airways are open or if we need to treat with oxygen. Naloxone for opioid toxicities, very common, very helpful. One thing to remember about it is that if we see a lack of response to it, is it that the opioids are not the cause, or are we just not using enough?
That was day one.
And finally,
Oh shoot, I forgot I was on this meeting.
finally, we have thiamine in the don't mnemonic. Scan mnemonic follows a same system by telling you to check sugar, do a CT head if indicated to look for local lesions, ABG, VBG to check for metabolic causes, and finally N to check for narcotics and give empiric naloxone. Here we had some specific considerations. One was that we have to know the mental baseline and see how it changes, especially given that the patient with the multifactoriality of his presentation was prone to delirium. One other thing was that the patient is wheelchair bound and the pressure points should be assessed to see if we are missing any ulcers here. And here, one thing to remember is that we have to adapt our physical examination skills to the state of the patient. And it's really important, especially in this case, to do a full exam. Another thing to consider was the hypertension. The most important thing to know here was the rate of the rise, because the number of the hypertension we were seeing was really high, but if the rate of rise is not high, we may have to look at as a bystander and as a consequence of something else that we need to think about. Now, one thing I want to mention in the missed mnemonic, and I want to move on to this altered mental status itself, is that in the missed mnemonic, here we have to consider two most important things: structural causes and medications in the toxin group. First, I want to start with the structural causes. Here, we may see the apnea here is the guiding force for us. which narrows down our differential. We have to look for brain lesions that affect the respiratory centers or arise in ICP, with a pupil exam being the key here. One thing to never forget in structural causes is seizures. I like to mention them in the structural causes because first, we often forget about them, especially the non-convulsive ones. Um, but thinking about them as as subradiological structural abnormalities is helpful to remember them in the mnemonic, because as one of my attendings always says, if you don't mention seizures, you won't think about them. So here, I really enjoyed that it was mentioned and thoroughly discussed. Finally, let's go to the medication. Here, when we are reviewing the medication, we have to think about, is this a side effect? Is this a withdrawal syndrome? Or is this the intended effect of a drug that is being accumulated due to the AKI? Or maybe we are just giving too much. Several drugs were notable here, with baclofen being the final diagnosis, apixaban by suggestions of spontaneous bleeds following minor traumas, or, on the other hand, DVT and hypercoagulation following a missed dose. Insulin with the risk of hypoglycemia given the state of the kidneys. As the kidneys get worse, the diabetes usually get better in CKD patients. We have to remember that. Finally, the withdrawal symptom of the recreational drug they were using. And finally, we arrived at the final diagnosis. Baclofen, which was causing the apneic symptoms and the altered mental status itself. Thank you so much.
Okay, yes, superb, Kashar, and I love your pearls and the way that you organized it. It's a fantastic job for such a complex case. So thanks so much for everyone that came today and joined live, and we encourage you to continue to do so. Hopefully, Lynn will be back to present more wonderful cases like she shared today. But thanks again, everyone, and we will see you later this evening for a heme onc VMR that should be very, very interesting and with a couple of great educators. So look forward to that. All right. Have a good day. Bye-bye.